Welcome to the Evelyn Y. Davis Studios at the National Press Foundation. Coming up, a look at the latest in health information technology, wearables that monitor your sleep and your steps, digital health records that doctors can share, maybe, privacy, security, and resources for journalists. The National Press Foundation is a nonprofit dedicated to helping journalists cover complex topics with depth and accuracy. Our mission includes journalists around the U.S. and around the world. I'm Linda Topping-Streitfeld, Director of Programs at the National Press Foundation. With me today, reporter David Pittman at Politico's eHealth, covering politics, health, and technology, and Dr. Jacob Reider, Deputy National Coordinator in the Office of the National Coordinator for Health Information Technology, part of Health and Human Services. Your whole office exists to promote health information technology. Why is it so important?
So as the nation shifts from relying on, as some say, dead trees to record and transport health information, we're shifting toward information technology. We see this nationwide. We see it in physician practices. We see this in medical groups. We see it in hospitals, other care delivery settings like pharmacies. And so have you, audience participation time, Linda, have you gotten a prescription from a healthcare provider that was electronically transmitted to your pharmacy? You bet. So you didn't have something to lose. You didn't have something that could be altered by somebody who might find it on your desk or somewhere else. And it went from the healthcare provider to the pharmacy instantly. Right. If there's a conversation to be had, that actually now happens electronically. So as we've seen with most other industries, of course, including the one we're using right now, information technology makes the work that we do more efficient. We can do it better. Computers remember things that humans simply can't. I got interested in this industry about 30 years ago when I realized that as a family doctor, it was impossible for me to provide perfect care to my patients. I didn't remember everything. I didn't remember all the diseases. I didn't remember all the things that I was supposed to learn in medical school. And so we're shifting to an infrastructure for healthcare delivery in this country that relies on information technology. And so what our office does is it creates some of the guardrails and also gives some guidance to this industry about how to use standards, how to share information, how to keep it private and secure, and how to make sure that safety and better care quality are core components of how we leverage these tools going forward.
Okay, and we're going to talk about a lot of those things as we move through this webinar. I want to focus now on electronic health records. David, first of all, from a journalist perspective, does it matter whether you say electronic health record, electronic medical record? Is there a difference between those things?
Well, technically there's a difference, and I think Jacob might be able to speak to that. But for the public, from a journalist perspective, they're pretty much interchangeable. Electronic health records might be a little bit broader term. Electronic medical records might just be your clinical information that your doctor contains about you or knows about you. But generally speaking, they're fairly interchangeable.
Okay, so is that okay? Can we use it interchangeably now?
I would agree. In general, we try and talk about health rather than medical, because we're trying to help a nation be healthy rather than use a kind of a medical construct to think about how we are keeping a nation healthy.
Right.
Right. So instead of a care system, it's a health system. And so we try and use that term. And in fact, I find myself often speaking about health information technology rather than electronic health records. A record implies a file cabinet where stuff goes to sit. Well, as we've seen, these tools are very dynamic, and they actually help us make better decisions. They help us communicate. And so broadly speaking, health information technology is how I prefer to think about this whole domain.
So you've expressed a little bit why it's so important, and we've been talking for years of making an effort to move doctors and hospitals, other health providers into electronic records. Can you summarize that effort for us and bring us up to date? Where do we stand now on the effort to move everybody into electronics, and what's the current status?
Sure. So what happened in this country is that with the Recovery Act, the high-tech program was started. And so that was in 2009 that the high-tech program was launched. And the initial plan was that this would be 3 phases. So stage 1 would be adoption. So we would motivate healthcare providers, hospitals, doctors' offices to implement health information technology, because of course until something's implemented, we can't share the information, right? So I couldn't get email from my mom until she signed up for an email account. Right. Once she'd adopted the technology, then we could start to communicate. And so stage 1 was all about adoption. So that was essentially 2011 that the program started. It was launched in 2009 with the regulations. And then in 2011 it started. 2014 was really the end of the stage 1 entry. And so now we're just, in 2014, we're just starting stage 2. So stage 1 was about adoption, stage 2 is about exchange.
So let me stop you there. We had 3 years, 2011 to 14, for health providers across the board to adopt some kind of electronic health record system. How did they do?
Well, I think the latest data is awfully compelling. I think somewhere around 400,000, so 2/3 of practicing eligible providers, and about 95% of hospitals have adopted health information technology. So I would say stage 1, green light. We've got very broad adoption in this country, and in fact many other countries that were starting to adopt health information technology and we thought we were behind, we have now leapfrogged those other countries, and they are now saying, hey, how do you folks do this so quickly and so successfully?
As a reporter, do you see this the same way? Is this your perception that we're doing pretty well, 2/3?
Yeah, I mean, that's pretty well. I mean, there's a lot of people that are still trying to come along and adopt. I think a lot of small rural practices and hospitals are the ones that are mostly have not adopted, and it's important to not leave them behind for obvious reasons. But generally, for the most part, for the people, for the practices, the doctors that want to adopt them, they mostly have.
Okay, so we're ready for stage 2. Can somebody tell me what's coming up? What's stage 2, and what can we expect?
Well, I'll start, and then David, I'll hand the baton to you. The first thing that we did to prepare ourselves for stage 2 was that our office, the Office of the National Coordinator, defined certification criteria that would permit systems to talk to each other, for lack of a better term. And so the program, the Meaningful Use Incentive Program, says that you get this incentive money, so there's money that you get from participating if you meaningfully use certified EHR technology. And so the certification is defined by our office. And we define standards. So there are certain ways that you describe medical conditions. There are actually codes that you would use to describe a diagnosis. And there are very explicit codes that are used to describe lab tests or lab results or various things. And so we've defined criteria that these systems would use to communicate with each other. And the systems have now adopted those standards.
Are those codes the same ones that insurance companies have been using for years? When a doctor wants to bill you for something, they have a certain code that they put on the bill. Is it the same, or is it a different?
It's different, because for different uses, you need a different kind of code. And so as a clinician, as I think about how I would describe your condition, that's different from how a billing administrator would think about it. And so what we adopted, to answer your question explicitly, and if reporters want to look this up, we adopted a code system called SNOMED-CT to describe patients' clinical problems. SNOMED-CT is a coding system that's designed the way that doctors and other care providers think. ICD, the International Classification of Diseases, is a billing system. And so, and many know that there was a shift, or there's an ongoing shift in ICD from ICD-9 to ICD-10, which provides greater granularity. The National Library of Medicine actually has a mapping tool. So if a clinician describes something in SNOMED-CT, that tool can actually be used to map to the equivalent ICD-10 code. And so we, the government, have provided tools that enable folks to use the words that they are most comfortable with to describe patients' clinical conditions, and then have those codes be carried over to the billing systems where necessary.
As a journalist,
Mm-hmm.
what is the biggest challenge in covering all of this?
Well, it's kind of twofold. One is sort of it's a little bit of an abstract topic when you talk about the benefits of it. Improve the health of patients, and being able to share information, and hypothetically, if I am in a car accident and I'm halfway across the country, can the doctors there get my information from my primary care provider where I live? That's sort of theoretical, it's a little abstract to sort of the benefits of it can be a little bit tough to explain to editors and get across in a 500-word story, for example. It's also technical because and you mentioned like ICD and SNOMED. You get some of these technical terms that they're one, difficult to understand, and two, difficult to explain. So it's sort of the technology and sort of the jargon of it. It's hard to come across and like I said, both sell to an editor and make clear to a lay audience.
I would agree. This is a very technical domain. It's sort of like the other things that we look at in other technical industries. We don't really ask for the details of how cell phone works. We just kind of know that they work, and there are standards, and we know that the phone companies abide by those standards. And so trying to cover a very technical space, I'm sure it's very difficult, and we often interact with folks like David and help them understand things in a way that they can explain things to their editors and their readers. I think that's a lot of the role of our office, is to help translate.
Well, that's actually a good segue. In a minute, I think we're going to put up on the screen a list of resources that David put together for journalists, which are just some links to places you can find information. David, do you want to kind of go through and talk about those links?
Yeah.
And how they're helpful and what their limitations are?
This is just a very quick overview of some resources that folks can have that give you both an idea of what has been occurring in terms of adoption and the money that has been paid out through the incentives that the HITECH Act basically allowed for. The first one, it can give a lot of information. It's stuff that the Centers for Medicare and Medicaid Services gives pretty up to date. I think it's through August or September as of now, about like I said, who has met the standards of the HITECH Act and who has received money. It breaks it down pretty specifically through both Medicare and Medicaid and state by state. The second one is sort of I guess an industry resource from a group called American EHR. It's mostly ran by a group of internal medicine doctors, and it's their sort of electronic medical record resource for doctors and the public. The American Hospital Association also has a pretty robust data set about the use of health IT amongst hospitals. So that's the third link up there.
And all of those resources are available to the public, to journalists. This isn't something proprietary that hospitals are keeping close to their vest.
Some information by the American Hospital Association is. I mean, they have a lot of information, but the high level stuff that they have publicly made available. The 4, 5, and 6 are basically what I could find as some of the most recent national surveys of EHR adoption levels, both for doctors and for hospitals. The CDC and its National Center for Health Statistics does pretty regular surveys on health IT adoption for both hospitals and doctors, and that's out there. And the last one is actually from the ONC, Jacob's office, about acute care hospitals and their adoption levels. I think there's a pretty broad national snapshots. It's a lot more difficult to drill down to a local community level.
Right.
In which case, state, either hospital associations or state medical societies might possibly have some information about what's going on in your state or community, and always depending on how large or small your community is, asking the individual hospital what their level is, and they have received, I'm not sure we've spoken about it very much today, but they receive incentive money to be able to offset the cost of adoption. So most hospitals have or are trying to seek this money, and if they do gain it, my opinion as a journalist, they should be able to tell the public what they have received, how much they have received, that sort of thing. So
I'm glad you brought that up, actually, because we should talk about the incentives and how, now that we're into stage 2, there's a change in incentive money. Is that correct? Jacob, can you speak to that?
Well, the program is a step-by-step program.
Right.
So the initial few years of the program, if you're a hospital that started in 2011, the amount of incentive actually diminishes over time. So this was, as they say, front-loaded to get folks on board, and the quantity of the incentive, both for a healthcare provider and or for a hospital, diminishes over time. But there's also another change, which I think is the one you're talking about, which is that it turns into a penalty. And so there's a penalty that is applied to Medicare reimbursements that actually start in 2015. The basis year was 2013. So if you weren't using certified EHR technology in 2013, in 2015, you'll actually start to have a penalty applied to your Medicare reimbursements. Now, there are ways to get out of that penalty in many organizations because they hadn't implemented yet, or there were reasons for there not to have been implementing, are avoiding that penalty, and that's as David's about to opine, perhaps. This is complex. It's complicated about who gets a hardship and who gets a hardship exception, and who is having the penalty applied. But the broad stroke for folks to understand is that this has gone from an incentive program to, in the future, what will be a penalty program, where if you've not adopted EHR technology, you're not going to get as much money from Medicare as you would have.
Mm-hmm. And the determination of who gets money and who is penalized, that's something that CMS, the Centers for Medicare and Medicaid Services, makes that decision? That's
right. So the ONC, as I described earlier, we define the certification criteria: certified use of, meaningful use of certified EHR technology. Right. The meaningful use, and what meaningful use means, is defined by CMS. And the metaphor I sometimes use when I talk to my mom is that it's like a 16-year-old taking a driver's test. It's meaningful use of a car. The car needs to be certified. It's certified to do a certain set of things. Those things, turn right, turn left, stop, require functionalities of the car to be there. Brake lights, tire treads of a certain depth, and so on. The meaningful use, what you have to do, the three-point turn and all that, that's defined by CMS and exactly what needs to happen. So obviously these two programs are closely tied, because if CMS expected folks to do stuff that the systems couldn't do, well, then no one could reliably do that. And so that's why we make sure that the systems can do the things that CMS expects folks to do with them.
Is there any difference between nonprofit and for-profit hospitals in terms of what they are required to do?
No.
No.
The biggest difference there comes, and there's a special set of outlays for critical access hospitals. The most rural and small hospitals that are out there, but to answer your question, no, there's not a difference between private, for-profit, or nonprofit hospitals.
Okay. There are lots of obstacles to meaningful use, and we've touched on some of them. We've talked about cost. These systems obviously are very expensive, which is why the incentives were offered and why they were front-loaded. Do either of you see the cost of the systems or of implementing or using those systems coming down as almost all other types of technology have through the years?
You might have a different answer. I'd probably say no. At the very least, it'd probably stay the same. If there's constant updates and new systems, and you have to add to new bells and whistles. You have to do this and that, and updates that frankly, for most hospitals and doctors are, well, it's a struggle to sort of keep up with financially anyway, because that costs the EHR vendors money to do. So that's sort of a cost that's passed on to doctors. So it's not as if you adopt this system and you're good to go for a lifetime. There's constant maintenance fees and licensing fees that you have to always pay to keep using it. No, I don't see that really changing when more requirements are added in the future.
As David predicted, I have a little bit of a different take on that one. So we're not seeing drastic shifts yet in how much these systems cost to implement and maintain. So I would agree in general there aren't extraordinary changes, but we actually see them coming in the future, and some of that is represented by a migration from so-called client-server implementations, where someone will stick a server in their server closet and manage the systems internally in-house. And we see this both in doctors' offices and in hospitals, right? So a client-server system is not a web-based or cloud-based system. And so we're seeing migrations and people taking advantage of the efficiencies of so-called cloud-based or web-based systems, which actually is reducing some of the implementation costs. It's reducing some of the maintenance cost. And so rather than send a CD out to 15,000 doctors' offices and then, of course, need a herd of implementation specialists to implement the upgrades, when Amazon changes their systems, we don't notice it, right? Because they've just changed it. This is now happening in health information technology. So thousands of healthcare providers are using web-based systems that change automatically overnight. The upgrade just happened. It's not something that we change the practice and we shut down and we stop seeing patients on Thursday afternoon. This is the way that things were, and it's migrating toward the way that things will be. And we actually see that happening in hospitals as well, although not as quickly.
Mm-hmm. So cost is an obstacle. Maybe it's going to become a little less of one in the future, although with penalties being added, we'll see where that goes. What are other obstacles to continued adoption and meaningful use?
I think a common complaint by doctors, which most people have probably heard, whether they cover this issue closely or not, is just kind of usability. Doctors want to feel like they're talking to patients. They want to feel like they're practicing medicine and not, looking at a computer screen or data entry, putting in notes and checking this box and did I ask the patient about this? And doctors just, they're not necessarily consumer grade user friendliness and very intuitive like most people's smartphones are. It's just not necessarily that same level of usability, and expectations for doctors anyway hasn't necessarily been met, so their dissatisfaction with it is a little noticeable, put it that way.
Right, and I expect that'll be something that changes through the years as doctors get more experience with these things, and as, frankly, older doctors retire and younger doctors come in who are much more comfortable on a keyboard or on a pad.
And this is also very early in the process. A national coordinator, the guy who ran ONC a couple people before the current one, used this analogy to me recently, is that it's like the national highway system. If you looked at the national highway system in the 1950s, when it was first being started, you find car crashes were up and deaths, motor vehicle deaths were up. It's not very safe or practical to use, but if you some time later you looked at the situation again and asked those same questions, you find the situation a lot better. So this is very early in a long process, and the usability and other things we might talk about later today will certainly be improved over time, just as kinks get worked out and et cetera.
Right. Did you have any thoughts about that?
I think, as David implied, there's a lot to be said about usability, user experience, and I agree with you. It's both the facility of the users, the users' comfort with technology in general, but it's also the maturation of the technology. So we see usability as not this sort of very black and white issue as a product is either usable or not.
Right.
We see a spectrum of user experience, and we know that this industry is a little bit slower to migrate toward the usability perfection that we now see in many of our consumer electronics. And part of that makes sense because healthcare delivery is a very important domain. Safety of the patients is very important, and so we don't see these companies experimenting with new user experiences or new workflows as much as perhaps your smartphone would. If you get something wrong, and we've all seen the funny anecdotes about the autocompletes in our text messages, and it's funny, right?
Right, until it's my prescription.
Right, it's not funny if it's your prescription or your diagnosis. And so that's why, appropriately, health IT is a little bit slower to evolve than other industries.
And you mentioned safety, and I think that's something important to talk about. It's of course, related, though, to this issue of interoperability, how well systems can talk to each other, which we've alluded to. Why is that so difficult to make systems able to talk to each other?
I think we both could talk about this one for 20 minutes also. So interoperability is working. I guess I want to say that first. And we talked about your prescription that you got, and I've gotten them too. Billions of prescriptions are written in this country and transmitted electronically to pharmacies. The bulk of a patient's medical record, however, is much more complicated than just a prescription. If we look at the interoperability of other systems like banking, we can say, oh, well, banking, gosh, for 25 years we've been able to stick our card into a machine anywhere in the world and we get money out. And yet, the information that's transmitted with banking is a set of numbers, and generally a number identifying you and your account, and then one other number, which is a multiple of a penny, right? It's either one or some number of pennies that's being transmitted. Whereas the nuances of medical information that need to be represented in these codes that we talked about earlier, or in narrative, right? Margaret came in today and she smelled like urine, and I'm concerned about whether she's taking care of herself now. Now, that might be something that I would write in a doctor's note, and that conveys a lot of information about this patient. And yet, how do I convey that to another system so that it's automatically available to another healthcare provider? So there's some nuances and there's pros.
But that's the kind of thing I would think you could just be a document. I mean, we send written documents all the time. So why couldn't the general practitioner send to the specialist a couple of pages of documents?
Well, that happens. And then it turns into a telephone book, because it's never just a couple of pages. That as a primary care doctor, I can tell you, I get stuff all the time from my colleagues in primary care, from specialists, from hospitals, and that becomes the fire hose of information. And so there are ways of us to electronically transmit analog representations of our care, and ultimately that becomes impossible for us to consume or to understand. And so am I liable as a healthcare provider for page 347 of the chart that I just got in a massive PDF? Doctors are actually worried about that. So we need to send both the narrative that comes with it, but also maybe it's the med list, the problem list, the list of allergies, the things that you're allergic to, a very high-level set of explicit, semantically clear digital information that can go from one system to another automatically. And so those are the standards that we've been working on, and those are the processes. We talk about payloads, the stuff, and transmission formats. That's UPS or FedEx or the Postal Service. So we talk about those two components, and the telecommunications industry uses that. Email uses those two methods. And so we talk about standardizing those pieces, and that's what we've done with our certification programs.
And it's not as if this notion of interoperability, it's not as if it's not done anywhere. There are some communities, some states out there that do have systems out there that do a pretty good job at this. I was at an event this morning where directors of the Delaware and Massachusetts exchange spoke about this issue, and they have within their states, like I said, just sort of systems where different hospitals can talk to each other. They go through this sort of a centralized hub and then back out. So there are different levels of success with this, in spite of sort of the more national struggles. If journalists can look at their communities or their states, they will find different levels of success in doing this. So those are sort of questions to ask or things to look at for journalists within their individual communities.
And I would add that for journalists to think about things that would resonate with consumers, we've actually tried to focus a lot on where am I, the patient, the person in all of this, and what's most important to me. And so we've added, both CMS added for stage 2, and we added requirements for these systems to be capable of giving a patient ability to view, download, or transmit their record. And all three are really important. So view means I can see it on a website, maybe it's a portal or some other method. Download means I can download it. I can put it on my flash drive or my cell phone, or I can put it wherever I want to put it. And transmit means I could send it to somebody else. And so sometimes we think of the patient as being the method of moving information from place to place. Not necessarily the only method, but if you want to take control of your digital health information, you can. And that's actually a requirement of the Meaningful Use Incentive Program, that you be able to view or download or transmit your information.
Right, and I think that's an element of it that's going to be very exciting for a lot of consumers out there who really want that opportunity.
That's right.
Did you have anything else you want to say about that?
No, I think that well sums it up. There's a lot of consumer element to this, which people can really, I spoke about earlier, it's difficult to relate or sort of make this applicable to patients in some ways, because some of the resources, the benefits of this can be a little abstract, but this is one way in which you can really make it personal to something that most everybody has experienced.
Absolutely.
And folks should feel empowered to ask their care providers, hey, where's my view, download, and transmit capability? And the brand that we have at the federal government have embraced is something called the blue button. And so the metaphor, of course, is there might be a blue button that could be used to view or download or transmit my health information that would be available to the patient. And so if patients can go to their healthcare providers and say, hey, where's my blue button? I thought you needed that for meaningful use. That can really accelerate the adoption of these kinds of tools.
That will surprise a lot of doctors. But let's talk about safety for a minute, because I'm imagining my health record digitized, floating out there in the digital world, and how do I know that my health record isn't going to end up on YouTube next to Jennifer Lawrence? Not that anybody would be looking at my health record at that point, but you get my point.
So privacy and security is very important to us. And I keep talking about the certification criteria. We require that the systems and the implementers use the tools in a safe and secure way. And so you can log into your information, but I can't log into your information. And it's supposed to be done securely and consistently securely so that your privacy is under your control. There are obviously laws. The HIPAA is one that folks probably know about, that defines some of the guardrails for that. And many may not know that HIPAA was modified, and I think it was about 1.5 years ago, to provide additional guidance in the health IT domain so that folks understand some of the specific criteria that they need to employ for privacy and security when they're implementing health IT. So that's very important. I think it's related to, but not the same as, safety, which I'm happy to also talk about, but I will make space for David here.
In terms of security, Jacob's talking about having passwords, everybody controls their own security. Is that foolproof?
No, and there have been very recent examples, high-profile examples within the health community, within the health space of health records being hacked and stolen, and the examples of Home Depot and Target are rampant in the retail industry. But within healthcare, just a couple months ago, it was announced that a large Tennessee-based hospital system, Community Health Services, had like 4.5 million patient records. It wasn't entirely patient records. There was like their names, addresses, social security numbers, certain identifiable information. I don't believe clinical information was necessarily linked to that, but still, this national hospital chain had 4.5 million people, their records stolen, and this sort of information is valuable to cyber criminals, just the same way as the information from Home Depot or Michaels or Target is valuable to them. They can, steal your identity. They can steal your credit information. It's worth all sorts of value to them. So it is targeted just the same way these large retail chains are. So just the fact that there are security protocols to follow and HIPAA to abide by, they still are vulnerable and susceptible to attack.
Right. I know you have people working on this in your office.
We do. We have a whole team that's focused on privacy and security. So we monitor these issues regularly. We provide frequent guidance to healthcare providers in this space. We actually have a tool that we developed generally for small practices to perform an audit on themselves to guide them toward the best practices so that they can avoid challenges like these. And so I agree with David. You got it right. There was no clinical information that was revealed in that event. The scale of these things is concerning, Target and this episode, and yet at the same time, in many cases, the digital information is safer than it is on paper. The cleaning staff has access to the chart room, and in the days of paper, we never knew if somebody read something or not. In the digital field, we actually have safeguards so that we can understand who looked at whose record, when, and why. And so we have very good tracking of, say, when a VIP goes into a hospital, we know who looks at their record. Well, we don't know, but someone knows who looks at their record, and the systems are actually required to have the capability to perform these audits to make sure that the only people who are accessing patient records are the people who should be and no one else.
And getting back to sort of what journalists can take home from this, hospitals are focusing more and more on this, realizing that it is an issue, realizing that information is becoming more and more digital. They are focusing more and more on they call them chief information security officers, not just chief information officers, but people who are focused on the security specifically of people's health records.
Yeah. So I would, local journalists should feel free to reach out to various members of the IT implementation teams, including a privacy security officer, chief medical informatics officer. So I would say, don't just talk to the press folks. Dig deep and ask the tough questions about, so what's your hospital doing for security? Or even a small practice, and asking small practices, so what are your security protocols, and how are you preventing patient information from being compromised?
Very good. Thank you for that good advice for journalists. Let's shift gears a little bit and talk about mobile health. So now we're really talking about things that are used by consumers. What is this all about?
It's sort of a way to use mobile technologies, your phones, iPads, whatever, to keep better track of your health, personal health. Whether it's most people, or I say most, a lot of people now wear Fitbits and track their steps, and you can track your what you eat, your diet, your exercise routines. That's not necessarily clinical information, much the same way as what your cholesterol level is, or what your cancer diagnosis you had a few years ago. But it's still related to the overall picture of your health, and mobile technologies are a way to keep track of that, and it's evolving to be more sophisticated, I guess, to where there's under development, for example, contact lenses that measure your blood sugar levels. So you don't have to necessarily stick your finger, but might be able to one day hold your phone up to near your eye, and it will spew out your blood sugar levels or something. Seems scientific right now, but these are things that are under development, and you never know what role they will play in years to come in the healthcare system.
As a doctor, are these things useful?
Absolutely. So the big question is how we will integrate these kinds of tools into what are new models of care delivery, right? This is no longer Doc Welby having a one-on-one engagement in an 8x10 exam room with a patient, and that defines the relationship between a healthcare provider and a patient. What these tools are going to do is they'll change the way we think about healthcare overall. It'll change the way we think about health. And so a clinician and a clinician's team will become resources to patients as we make decisions together. And so I'll give an example of an elderly patient who is homebound, and right now we might have visiting nurses check in on them 3 days a week because that's about all we can do. And I might get a phone call from a visiting nurse, well, it seems like Mrs. So-and-so isn't doing so well today. And that's what I get. But maybe if she has sensors in her house, we can actually measure what time she gets up, whether she took all of her medicines because her medicine bottles have sensors in them. And a nurse or a healthcare provider can be proactive as we watch things. And yes, there's a bit of a big brother feel to this, but as the son of aging parents, I can tell you I'd much rather have that, and in fact my parents would rather have that than not at all, because it makes them feel safer. And so as the healthcare delivery team with care providers and other folks participate in trying to figure out how we can use all of this data proactively to understand our needs, I think it's going to change the way that healthcare works. And as David said, that's not necessarily something that happens today, but it's very likely to be happening tomorrow and the next year and the next year, especially as we change the way we think about providing healthcare from lots of healthcare, volume as they say, to value, better health.
Right. This isn't something that we talked about, but it strikes me that all of these new devices are going to be costly, and people who have money obviously will be the early adopters. Is this going to increase the divide that we already have in this country between wealthy people who have a tendency to be healthier and get better care and those at the low end who maybe don't? Is that an issue?
I think it's an issue for us to always think about and be proactive with as we think about those challenges to make sure that we don't enhance a digital divide. I think in many cases, I mentioned the nurse visiting 3 times a week, that's very expensive. And a $200 device in the home is much less expensive. So if we think about this as a community, it's much less expensive for a community to invest in this kind of hardware and software and then remote services than it is to do the sorts of things with, I hate to say brute force, that we've done it with historically. So I think this is actually an extraordinary opportunity to normalize the kind of care that we provide to our communities. Right now, the wealthy will have time for, to bring in a full-time nurse to watch over grandma, and those who are less well off can't. Right. And so this technology will actually be able to provide better care, better monitoring, better proactive assistance than could the current models.
You mentioned contact lenses that might measure blood sugar. We're all familiar with the Fitbit, other types of things that count steps and tell us how well we're sleeping. Are there other things on the horizon that you're aware of or that are already out there that are interesting to consumers in terms of these kinds of devices? What's the next exciting thing?
There's a lot of, I don't know if this is necessarily entirely related, but there's a lot of growth in an area of medicine called telemedicine, where you can communicate to doctors via telecommunications. You can do it through your phone or through your iPad. It's a growing industry, growing field.
So are you talking about more than my simply sending an email to my doctor that says those pills you gave me are not working?
It's different for me because I actually cover the industry, but I can pull up my phone and have an app on my phone from a company that provides this type of service. I punch in some basic information where I am, and I can FaceTime with a doctor, family medicine doctor, depending on where you live, and the services provided. More specialist rather than just a family medicine doctor. It's when I started covering healthcare about 10 years ago, telemedicine was just a way to connect rural clinics and facilities with urban medical centers. These urban centers had specialists that these rural facilities just did not have. And that's still the case. There's still a lot of that going on. But there's also, it's becoming more common in urban areas. You know, I live in a city, but it still takes me 45 minutes to get to my doctor, depending on how I get there. And that's still a barrier. There's still issues with access, whether or not if I call my primary care doctor, can he see me that day? Does that have to wait? There's a lot of access issues, and there's a growing field of using the technologies that we have today, smartphones and such, to be able to meet this patient demand.
Right. So I can communicate with my doctor either by email, or maybe I can actually punch up a conversation with him or her as an individual. And we know there's still, as you said, rural healthcare providers who are accessing people in more urban areas who might have different specialties. We've also heard that folks in India may be reading x-rays from U.S. hospitals overnight, that kind of thing. Are there other ways that this, and is this important in terms of your office, the idea that there's mobile access to health resources?
So we think it's very important. The question is, what's our role? In my mind, government's role is to do what we must and nothing more, right? Because it's the opposite from normal humans, right? So Congress says, you can do anything you want unless it's against the law. Mm-hmm. For us, we can do anything we want so long as we have the authority to do it, mm-hmm. which means we should only do the things that we must do. So telecommunications, using mobile technology in order to administer health care, I don't think of these as different categories of care. I think of healthcare as healthcare. Mm-hmm. And the tools that we use, because technology is improving, it's getting smaller, as David described, it's changed the size of the world, right? And we've all heard and experienced that the world is a smaller place than it used to be, because technology has brought us closer together. We can communicate with people 12,000 miles away as if they're just next door. And sure, there are certainly cases where healthcare providers should make themselves available and can and will and should interact with patients, clients, whatever we call ourselves, electronically and using these electronic tools. And sometimes a text message will do, or an email. Sometimes a telephone conversation will do. Sometimes a face-to-face electronically enabled conversation will do. And sometimes we need to see each other in person, because that's what's important. And so we want to make sure that all of these things are done carefully, are done safely, and at the core of it, it's the best care for the patient that's the primary motivator. And so we've seen historically, and right now, the way that in many cases we pay for care, I've certainly seen it, maybe both of you have experienced it, when you call your doctor and you say, I have a question, and they say, well, next Tuesday afternoon, we've got 15 minutes for you. Come on over. Well, why is that? That's because of the way we pay for care. That's how they get compensated, is to see you in the office. So we need to think creatively about how it is that care gets compensated, making sure that the right care is still provided. So I don't think of this as a separate category. I guess that's my answer.
So, David, in terms of how people are reimbursed for different types of care, which you just mentioned, is that an issue that you've covered? For example, can my doctor not get reimbursed? Let's say I'm on Medicare. My doctor won't get paid if he talks to me on the phone?
In Medicare, no. Medicare is so restrictive in what it pays for. There are very certain parameters that you have to meet in order to get paid as a doctor through Medicare.
What about other insurance companies? Does anybody pay for that kind of interaction?
Yeah, and in the private insurance, it's more and more common. They'd rather folks want to pick up the phone and call somebody rather than go to the emergency room or go to the urgent care, which is still not expensive. It's certainly less expensive than, or more expensive than a telephone call. So private insurance is definitely a lot more, I guess, forward-thinking in this arena. So yeah, again, like most insurance, it depends on where you live and who you are, and but they do reimburse for this type of care, generally speaking.
Is it changing?
Well, so good segue. I would agree with David in general, although CMS Medicare has some innovation programs where there are also opportunities for healthcare providers to join together in groups. And one of the projects is called the Accountable Care Organization Project. And so reporters might want to ask around in their communities to see if anybody's participating in an ACO, or Accountable Care Organization. And some of them are led by physicians, and some of them are led by hospitals gathering physicians in their communities together. And what one does when one enters into an ACO program is one says, well, we're going to take responsibility for helping this population be healthy. And then whatever creative things that group does, maybe it's the group invests in putting handles in the bathtubs so that there are fewer falls and then fewer hip replacements that need to be done. We wouldn't think of this as an innovative program. It's not using technology, but in fact, there's good evidence that that saves money and improves the quality of life, and in fact may save lives. An accountable care organization that would be investing in the health of a community would do those sorts of things. And so the way that they're paid is very different from the fee-for-service kind of models that we are currently accustomed to. And we're seeing this migration happening both in the commercial space and certainly in the federal space. Over time, there will be delivery system reform that aligns better with the needs of the patients rather than the needs of the financial statements of the people providing the care.
Right, and to just bring this full circle, I think the accountable care organizations have an emphasis on integrating the electronic health records to streamline the care that they're providing.
Absolutely. They couldn't do it without health information technology. And we view health information technology as the foundation of any improved care delivery model. And when we look at operations that are doing this nationwide, health IT is really the core of what they're doing.
Yeah, and I think for journalists, looking, as you suggest, at the accountable care organizations in your own community and what they're doing that's different from how others are operating is a critical piece, as well as looking at who's left out. What happens to the doctors, the sole practitioners, small clinics, and so forth, who don't get involved in an ACO? Are they going to be left behind? Can they afford to incorporate electronic health records? All of these questions I think are great for journalists to ask. And
within Medicare, most communities have at least one accountable care organization operating around them. There's several hundred, I think about 600 nationally. So by and large, but the odds are that there's at least one in your community depending on where you live.
Right, terrific. Is there anything that we have not talked about that we should bring up before we close?
So we haven't talked explicitly about quality. We've talked some about safety, and that's something I always want to make sure we discuss. As we think about what we were just saying, thinking about accountable care and how we reimburse better for better value, the way that we need to assess the value is some kind of an assessment of the quality of care that's provided to the patients in a community. And so we're working hard to figure out how we can have the health IT systems do a better job of measuring quality of care. What are the outcomes that are most important to us? Turns out that patient by patient, it might be different, right? So maybe living a long life is important to one person, but in fact being able to ski is important to somebody else, and preserving the quality events in our lives. Are the screening tests that should be done being done? Are the patients who should have mammograms or colonoscopies or cholesterol screenings, are we doing those things? Are we taking care of our patients with high blood pressure? With information technology, we can measure those things on a population, and we can tell, well, this practice seems to be doing very well in this domain. This practice may not be. So I think quality is another thing for folks to think about and ask questions about as we learn about how our communities are using health information technology to improve the quality of life for their communities.
Absolutely.
You had asked earlier, what is some of the difficulty in covering this, and I mentioned, it's hard to sort of explain to an editor or get across to a reader, but for the reasons you just explained, it's important for quality reasons. It's important because this is our health system, and IT is not a small part of it by any means, and it's only going to be more important. So this is important to ask these questions of people in their community and in their states who are in charge of this, to hold them accountable, responsible for making sure this goes well, this goes right in their communities and their states, because it's important.
Absolutely, thank you. That's a great closing word. Thank you very much, David Pittman from Politico eHealth, and Dr. Jacob Reider, Deputy Coordinator in the Office of the National Coordinator for Health Information Technology. Webinars ahead this month. Survival Strategies for Your Journalism Career on October 16th with Jody Schneider, and a fascinating conversation with NPF's Bob Myers and Ambassador Valentin Zellweger on October 23rd. We'll explore the intrigue around looted national treasure in Swiss banks. You'll find the full schedule at our website. Please sign up for our newsletter. Use the donate button on the homepage. And thank you for joining us in the Evelyn Y. Davis studios at the National Press Foundation, where we are making good journalists better.